Hi, everyone. Hello. Welcome to our new episode of the After Work Chats. Today it is Thursday, which means that's me and LK again doing our stuff. And first of all, welcome, LK. How are you today?
I'm doing good. Thank you very much for having me again, Lep.
My pleasure, my pleasure. And today we're going to be talking about upcoding. And I came to this topic by actually, it's like big thing now in America in the news with all the changes coming in the government. They're talking a lot about changes in the healthcare system as well, and some changes to Medicare as well. And I was some actually doing some my scrolling through news, and I saw something interesting popped into my feed, which is upcoding. And I didn't know what it is, and it's like apparently a really big thing with Medicare, upcoding with Medicare. But before we go into this, to all the viewers that are not not familiar with the matter, and some people don't know what coding is, I'm gonna ask LK to explain to to me and to others as well. What is coding?
Oh, sure. Basically, coding in healthcare, is basically a process of, translating medical diagnosis or treatment and procedure into standardized codes. Usually, these are alphanumeric, right? As defined by a system like, let's say, we call them ICD-10 for diagnosis and CPT codes for procedures. And these codes are basically used for billing, reimbursement from insurers, including government funding programs like Medicare, right?
Mm-hmm.
And basically, it's essential for ensuring that consistent communication between the healthcare and the providers, which is basically insurance company, then other stakeholders, right? So
Okay.
it's basically fundamental part of healthcare data management and impacting everything from patient records to insurance payments and healthcare analytics.
And it's universal. It's not only for Medicare. I assume it's
Mm,
for every for
Yes,
any insurance company, any
yes, it
procedure.
is.
There's a code. Okay.
Yes.
So basically, my understanding, I'll give some of my understanding of coding as well, just from like LK is an expert. He's been doing this for too long, and he knows like a lot of technical stuff. I'll try to explain like my own words. Is basically whenever you go to the doctor and you have any procedure or any lab test, any lab result that has to be ran on you, any test, any MRI scan or whatever, there's a code for this specific code that can you can specifically say that I don't know, I had an MRI other day on my elbow, but like a specific MRI. And by this code, everybody knows the healthcare, I mean the hospital, the insurance company, everybody knows what we're talking about without uh saying the words, just the numbers. And the codes, coding the codes are the numbers. Is it right, LK?
Yes, these are
Okay,
numbers.
okay.
These are
So
alphanumeric.
yeah, okay. So that's what coding is. Now the issue is coming from upcoding, and upcoding
Yeah.
is I assume from what I understood and from what I read, and LK can correct me if I'm wrong. Upcoding is happening a lot with Medicare, and not that much with private, not private, but with other insurance company. And it's specific to Medicare Advantage platform.
Yes.
And with Medicare Advantage, the thing is that basically you pay in advance. That's the difference. With just with the regular insurance plan, you pay month by month. Well, the government pays, but basically somebody pays it month by month. With Medicare Advantage, you pay upfront for a whole year, all inclusive. That's basically what the Medicare Advantage program is. And now with upcoding, what some healthcare companies do, or some providers do, they upcharge and make patients appear a little bit more sicker and increase annual capitation. Annual capitation is this, as I mentioned, that you pay basically for full-time service in advance. Annual capitation payment that Medicare Advantage pays to the hospital or to private insurance companies that offer Medicare plans. And this is a big issue. And I'm just going to go through some stats so people know. People love numbers. I love numbers. It's easier to understand this world with numbers. And All those are in public domain. I didn't get any of this. I went into uh, well-established media like New York Times or some other magazines. So I'm not taking anything out of my head. So some stats. Medicare upcoding on Medicare Advantage is responsible for 12 to 25 billion dollars in overpayments each year. It's a huge number. That just being uh, upcoding for not procedures that are not even needed. Moreover, that there's an estimated 30% of excess health spending to cover that just covers administrative costs of insurance, administrative costs borne by clinicians. That's another thing. So that's 30% that just going for administrative costs. They're not going for the procedures itself. Now, one more thing that I want to, and I'm just looking through my spreadsheet here so I don't make any of the stuff up. The system itself is so hard, and LK will talk about maybe, well, LK knows about it, but just so everybody knows, the system is so like hard to deal with that physicians spend at least 11 million hours on prior authorizations requests for Medicare Advantage per year alone. Just so imagine 11 million hours spent, okay, cumulatively by all physicians on Medicare Advantage alone. So if you count everything, all the other plans in, that's huge amount. And then, um, yes, there are some other numbers that I wanted to mention, but they're not as significant as those are. But now what I want to emphasize and I want to like talk a little bit into this because it's a huge issue. Like if we spend that much time, and the main thing is with Medicare that it's coming out of taxpayers' money, so it's basically government funds that are great. My personal opinion, it's good to have this system. Maybe there are some improvements that has to be done to any system there is in the world. It's not perfect. So, but this is a huge improvement that I think is possible in the future, and there's a big flaw in my opinion, because spending up to $25 billion of taxpayer money just because somebody's upcharging for procedures that are not even needed, I think it's unnecessary and can be somehow mitigated. I'm not an expert, but I think it's something we should strive for. But now with LK here, I want to ask him, so explain from how would you think? I assume you're an honest person and you don't do any upcoding. I hope so. From what I saw and from me working with you, you don't do any of this, and by no means we encourage any of those practices. But this could be done. So I just wanted to ask you, how is it possible that they are able, the physicians and clinics are able to upcharge, upcode, and get more money out of Medicare?
Well, Gleb, first of all, you explained it pretty well about the upcoding, and this is totally unethical coding. Instead of, they given it a, some sophisticated name by calling it upcoding. If it was me, I would have called it the unethical coding.
Mm-hmm.
Right, because in upcoding, as you explained, practice, where healthcare providers assign a code, to that reflects more severe diagnosis. Basically what they do is the billing side, it shows that it's more severe diagnosis that the patient needs. It's a complex procedure than what was actually delivered, and they are
Mm-hmm.
claiming more. The intentions are behind upcoding is to increase the reimbursement from the insurers.
Mm-hmm.
And that's particularly a system like Medicare Advantage, which you said, and now $250 billion is going into the loss for that. Right, that's a lot of money, right, from the taxpayers' pocket.
Yeah.
And this is what we always discourages such practices where you have to go with unethical coding. Anything out there should be like crisp and clear to both parties, right? From both parties. Upcoding often occurs through subtle adjustments in diagnosis, documentation. For example, let's say a provider might list a complicated vision or of complicated version of of a condition rather than a simpler one, or
Mm-hmm.
use codes that reflects chronic or severe illness, even if patient's actual condition is less severe.
Mm-hmm.
So additionally, healthcare organizations sometimes encourages the practice, by training or suggesting those diagnoses, that increases reimbursement, making it seem standard and even necessary to maintain. So, and this enable, the complex coding system and the subjective nature of the, certain diagnosis, which allows for some flexibility. But when healthcare organizations push, physicians to code creatively to secure financial bonuses, they're essentially, incentivizing this gray area. Basically, they are giving benefits to the, to sometimes doctors, providers, nurses, or people involved in that upcoding, or giving out false diagnosis. Not exactly false. It's kind of a same diagnosis, but showing it as a severe diagnosis. The
Mm-hmm.
upcoding, though it's profitable for some, but ultimately, drives up cost for, the whole system, and shifts resources away from patient, centered care,
Yeah.
and more towards, making money out of those, procedures or patients. And then it affects the end user, which really needs,
Mm-hmm.
uh, you know services from the insurance or the insurers to get that. So there are more and more, restrictions. There are more and more for the payers, actually. So the money is going out of payers pocket. The patient who has to receive that benefits, they sometimes has to go through a lot,
Yeah.
and then the premiums are increased for everyone.
So
And
so basically, from my understanding, is upcoding the I would say like techniques for this is basically the doctors are saying writing down problems that are not like actual problems on the chart and then
Mhm.
submitting codes that are not
Not
basically
always
those.
the doctor is involved, lab here, right? We cannot
Uh-huh.
blame everything on the
No,
doctor or
I'm
the
at like
provider.
clinics. Let's put clinics. I don't want
Right.
to say doctors.
Clinic,
Clinics.
or sometimes even a billing team.
Billing. Okay.
A
Okay.
billing
Yeah.
team can be involved in this. They want to make more commissions out of it because it's incentivized.
Mm-hmm.
It's all about the clinic, how the clinic works. The clinic wants to get a better, revenue, right? And they have asked their billing team to go ahead, this is how much they're giving them a target, basically. There are clinics who give targets to their billing team that,
Yeah.
this is our quarterly target. And if we achieve this, you guys will get this out of it, and this is what your commissions would be. Or sometimes they give that opportunity to the providers as well and tell them, just go ahead and, make it more look more severe, some of
Yeah.
your procedures, and we will give you this and this and this. Though they give them some bonuses, some stuff like that, which is unethical. Right? At any level, right, that's unethical. Right? Any company is doing that, that's also unethical.
Yeah. That's what I hear a lot that I'm like reading, but this like the healthcare system itself is hard to change. I know, and I
Right.
don't have a better solution. But a lot of people are saying that for profit medical care is bad for health because they're thinking more about profit, and as you said, more about charging and more about hitting um the like how you call it, hitting the some threshold of profit for quarterly or yearly. That's instead of focusing on patients and on patients care. And I think that's something that can be done about it because one other research that I forgot to mention is it's a Commonwealth fund analysis, and they analyzed 10 wealthy industrialized countries, 10 of the wealthiest, and where US ranks dead last in health outcomes, despite spending twice as much per capita compared to the other countries in the survey. And that's saying something that America is spending a lot from taxpayers' money, and maybe me just paying for my procedures that I'm not a Medicare. I'm paying out of pocket, but then still the outcomes that are not great. Maybe there's something has to do with the billing or the goals that are set for the billing team to set to reach and to meet for the quarter or for year. And I think that's a big issue. That's unfortunately, well, we can't fix this. We're fixed it at our place, but other than that, we can't. We're not working with any other clients like this. We don't know clients that do this, but apparently they are bad actors. And I mean, I don't know. who's involved as a billing provider. I don't want to blame anybody, but I'm just saying that up to $25 billion a year, that's a huge number. That's just being wasted instead of spending for better things. And on that terrible disappointment, or maybe well, there's something that has to be done, and I think it will be done, and I think I'm optimistic about the future. Thank you, LK. Next Tuesday, we're going to be talking about more things that I found on the website. The way I source the data, I'm curious. I don't have a lot of experience in healthcare management. I do have experience in healthcare overall, both sides, all sides, client, management, billing, insurance, but not specifically in management as much as LK does. So my curious head, I just scroll through news online and I find something interesting, and then I decide, okay, LK, let's talk about this because you have more experience than I do. And I hope this is interesting to you guys as well. If there's something more that you want me to talk about, obviously leave us a comment. You can you can find my phone somewhere on the website, and you can even call me, send me a text what you want us to talk about. Leave us a like, subscribe to our channels. We're everywhere. And have a great day, everybody. We'll see you next Tuesday. Thank you. Okay.
Thank you. Thank you, Gleb.
Bye.